All right, welcome everyone. Welcome to this breakout. We have state pioneers in maternal mental health, New Jersey's publicly funded maternal mental health program. My name is Brooke Lerman. I work with 2020 Mom. I wanted to remind you that this session is being recorded. A PDF of the PowerPoint will be in the Hoova platform for you to view after the session. If you do have any questions during the session, please add them to the chat feature in Zoom. And we will be keeping track of them and have a Q&A time at the end of the session. And now I will turn it over to our wonderful speakers to introduce themselves. Thank you.
Hi, everyone. My name is Kathy Donaldson. I'm the program manager of the Pregnancy and Parenting Wellness Program at Central Jersey Family Health Consortium. Quinn?
Thanks, Kathy. Hi, I'm Quinn Injemy, and I'm from the Southern New Jersey Perinatal Cooperative, and I'm the Assistant Director of Behavioral Health Programs here at the cooperative, overseeing 4 different programs, one of which is our Postpartum Wellness Initiative, which will be the program that I'll be speaking about today. Evie?
Good afternoon, everyone. My name is Evelise Gonzalez. You can call me Evie, much easier to pronounce and memorize. I am the program manager for the Emotional Wellbeing Program at the Partnership for Maternal and Child Health of Northern New Jersey.
We're going to start off with just an overview of the history of our programs in the state, and then each of us will give you some information about how we use our funding from the Department of Health in our own programs. So this is what we'll cover. As I just said, the history, and then we'll talk about each of the individual programs. So back in 2005, our acting governor at the time, Richard J. Cody, proposed legislation regarding postpartum depression screening and education. Because his wife, Mary Jo Cody, suffered from postpartum depression after the birth of one of their children. So that was his motivation. There are 3 maternal child health consortia in New Jersey. We serve all 21 counties in the state. We're all nonprofit 501c3 organizations that are licensed and regulated by the New Jersey Department of Health as central service facilities. And you can see the Department of Health's description of what the consortia's mandates are. Basically everything from soup to nuts for pregnant women and children under the age of 5. The initial scale up of the Perinatal Mood Disorders Initiative, excuse me, started with the gathering of a statewide speakers bureau, which is comprised of about 100 clinicians. I was one of them, and we traveled around the state providing 2 hours of standardized education statewide. The statistics were that we provided education to 4,500 clinicians in a 9-month period. And you can see the types of clinicians that were educated during this period. So it was pretty vast, from OB providers, pediatric providers, community agencies, therapists, etc. This is a graphic of the timeline. In 2006, when the legislation was passed, New Jersey was the first state to pass such legislation that mandated prenatal and postpartum education, as well as postpartum screening for all of the birthing hospitals in the state and the OB providers. In 2007 is where the funding came from the New Jersey Department of Health to the Maternal Child Health Consortia for our Perinatal Mood Disorders Initiative. This followed in 2010 when the American Academy of Pediatrics recommended postpartum depression screening during well child visits. And in 2016, excuse me, the U.S. Preventative Services Task Force recommended perinatal screening, followed by 2018, where the American College of Obstetricians and Gynecologists revised their committee opinion to recommend routine screening for perinatal mood and anxiety disorders during the perinatal period. So our legislation has not changed since 2006, and the legislation mandates education regarding symptoms, screening for postpartum depression specifically, diagnosis and treatment, as I said previously, during pregnancy and the postpartum period, also not only to mothers and other birthing people, but to fathers and other family members when appropriate. So, that's been in place since 2006. It also mandated that new mothers are screened prior to discharge from the birthing facility and at the first few postnatal checkups. A program was created by the Department of Health called Speak Up When You're Down. Brochures were created, two different brochures in multiple languages, and I'll show you pictures of the brochures in a few minutes. They also created a toll-free helpline, which is a 24/7 helpline where mothers can call and get help for postpartum depression. They are eligible for up to 12 free counseling visits if they are uninsured or underinsured and Medicaid recipients, and that's regardless of immigration status. These are the two brochures that the state created and are still distributed today. The one on the left is specifically for mothers. The one on the right, as you can see, is targeting family and friends and how they can be supportive of a new mother. Evie and Kelly, who's Quinn's colleague from the cooperative, and I just revised the Recognizing Postpartum Depression brochure to update it a little bit. So we're looking forward to that changing. At the initiation of the program, the state also had public service announcements that were broadcast on local and regional television stations within New Jersey, and also the New York and Philadelphia area stations that have New Jersey broadcast. And we also had radio PSAs. So today we are 3 maternal child health consortia. When we started out, I believe there were 9. So we've merged and we are now 3. And as I said, we cover all 21 counties. The 800 Speak Up When You're Down number is still in existence. And those up to 12 free counseling sessions are still available. One change is that mothers can no longer be underinsured. To qualify, they have to be either uninsured or be a Medicaid recipient to be eligible. Each program at each consortia has the same goals, but we have different frameworks for the services that we provide. And I've bulleted the services that we all provide just in different ways. So now I'll hand it off to Evie.
All right. It's like tag, I'm it. Good afternoon, everybody. Like I had said earlier, my name is Ivelisse Gonzalez. You can call me Evie Gonzalez, much easier to memorize and pronounce. I am a social worker. at heart, and I am the program manager for the Emotional Wellbeing Program at the Partnership for Maternal and Child Health of Northern New Jersey. And I'm going to go into detail about the different components of our program that serves as a continuum of care to increase support for patients during the perinatal period in Northern New Jersey. Next slide, please. I have nothing to disclose. Next slide. Okay, so I just want to start off by talking a little bit about our consortia as a whole. Like Kathy had mentioned, there are 3 maternal and child health consortia in the state of New Jersey. Originally, we did have 9. Now we're down to 3. So our agency, the one that I work for, covers all of the 8 most northern counties in the state. Our agency is licensed by the New Jersey Department of Health, and our main mission statement is to improve the well-being of women and children and families in Northern New Jersey. We service all of the 8 most northern counties, and we have over 40 grant-funded maternal and child health programs. That number is constantly rising, and a lot of the programs that we do have are related to maternal and child health in terms of like home visitation programs. We have a fatherhood program, 2 family success centers, and a teen pregnancy prevention program, and that's just to name a few. If you are interested in learning more about our services, I definitely encourage you to check out our website so you could learn about what it is that we do in the consortia. So in our catchment area, we do have 24 birthing hospitals, and we do have 2 birthing centers. And then part of what we do at the partnership is we monitor and analyze births in our region. And for the year 2021 alone, we had 47,047 births. Next slide, please. So I just wanted to throw this slide in here to kind of talk a little bit about the makeup of Northern New Jersey so you get an idea for those of you who are not from this area. So our Northern New Jersey area that compromises almost half of New Jersey's population, and women account for 51%, with over 800,000 women being of childbearing age. We have a very, very diverse region with some counties that tend to be very affluent, and then we have others that do fall way below the poverty level. Some areas are very urban, while others tend to be very rural. And one of the things that's interesting about our area too is that we do border between 2 states. So some of the region in the tippy top of the north borders New York, and then we have some regions that are within the western part of the state that border Pennsylvania. So in our program, we do tend to get some New York clients as well as Pennsylvania and New Jersey. Next slide, please. So I don't have to go through all of these details with you, because for all of us in the room, these are all facts that we've heard about before. But I just wanted to include this slide because it shows why we started this emotional well-being program. As you can see, approximately 20% of birthing patients report postpartum depression after giving birth. We have about 900 patients that suffer from postpartum depression annually, including those that have experienced a perinatal loss. And we know that 50% of individuals that are struggling with a perinatal mood and anxiety disorder go untreated. Perinatal mental health, it doesn't affects people from all different types of backgrounds, but there are a lot of barriers in accessing care, and they tend to vary from person to person. And our follow-up program is basically, the main gist behind it is to ensure that new clients are getting connected to the mental health services that they need and the mental health services that they deserve. Next slide. So the nitty-gritty of our emotional emotional well-being program is that we do provide training, support, and information on perinatal mood and anxiety disorders to agencies that are serving perinatal clients in northern New Jersey. So our program can be based and broken down into 4 major components, which I'm going to go into in a lot more detail. The first one is we do provide a lot of professional and consumer presentations. We do have virtual support groups. We have an emotional health phone support program, and then we do put together community events. All of the services that we provide in the emotional well-being program are in all of the 8 northern counties of New Jersey. The staff that makes up my program consists of a staff of 5. I have a part-time person who's a perinatal mental health specialist, and then I have 3 full-time perinatal mental health coordinators, and then myself, who is also a full-time program manager. Next slide, please. Okay, so what is our target audience for our program? So when it comes to the professional education piece, our target audience is hospital and clinic-based perinatal healthcare providers, as well as community-based agency staff working with expectant and new parents, but pretty much anyone that's falling in that perinatal period that they work with. That's usually our target audience for professional education. When we're looking to do community-based education and or our virtual support groups, as well as our emotional health phone support program, the third bullet point is our target audience for that. And we service anyone who's pregnant or has a child up into the age of 1. Anyone who's experienced a perinatal loss, has had a voluntary or involuntary termination of pregnancy, has decided on an adoption plan. And one of the things that we are going to be rolling out beginning July 1st of 2023 is that we do want to start incorporating those clients that are having infertility issues. Next slide, please. So when it comes to our professional and community education, it comes in a lot of different forms. So one of the things that we do is we put together conferences and webinars. The conferences and webinars are based on topics that are related to the maternal mental health field. But one of the things that I do pride ourselves on at the partnership is we're always looking for things related to maternal mental health, but topics that have never been discussed before. And this is a perfect example of a webinar that we do have coming up at the end of April, in which we are going to have a licensed clinical social worker who's going to talk about supporting perinatal mental health when a child has special needs. Another interesting conference that we have coming up in June is we are going to have a speaker who's going to talk about termination of a pregnancy for medical reasons. So one of the things that we're always trying to do when we're putting together conferences and webinars is we want to look at what's been done, what hasn't been done, and what are the needs of the providers in the areas that we work in that they feel that they need to be more educated on. When it comes to the in-services, those are typically done by myself or my staff. What we do is we go into the community, agencies that work with the perinatal population. We go into our birthing hospitals, birth centers, and we provide education on perinatal mood and anxiety disorders. We talk about all of the disorders. We've mainly focused on postpartum depression and postpartum anxiety because those tend to be the most common, but we'll talk about what are the symptoms, what are things for to look out for when you're working with this population, how to introduce screening to your patients, what are some follow-up conversations that you should be having with your patients after screening is done. And really getting into asking open-ended questions of your clients and doing what you need to do and learning the skills necessary to be able to solicit from the client what exactly is going on the inside. So we teach a lot of those skills in the in-services that we do, as well as provide them for resources that they can pass on to their clients. And same thing could be said with the trainings that we do. I think that would all fall under the umbrella of conferences and webinars. And aside from the professional piece, we do a lot of community education. We go into the community, we'll put together events such as baby showers, where we'll partner with an federally qualified health clinic or an agency that works with the perinatal population, and we'll just put together baby showers for those moms that are in need, that need the education, and we focus on different topics: breastfeeding, perinatal mental health, perinatal addictions, lead poisoning prevention, whatever it is that that community needs, we'll put these baby showers on to be able to educate them. There's two events that come to mind that we've done for the community. One was in October, we did an in-person event for Perinatal and Infant Loss Awareness Month, where we did a remembrance day for all of those clients that participate in our perinatal loss support group. And then another event that we have coming up in May for Maternal Mental Health Month is we are inviting all of those moms that participate in our virtual support groups to come out, meet each other face to face, learn about self-care, and have brunch together. So that's something that we're looking at putting together as well. When it comes to community events and topics to have speakers come and talk to moms about, we usually do that based on the feedback that we get from clients and what it is that they're looking to learn more about, or what is it that they need. And that's usually how we go about putting together those things. And then as far as resources, we do draft one-page handouts that we give to our member hospitals, our birthing centers, that we give to our clients themselves, that just focus on very specific topics. Next slide, please. And so this is just a handful of some of the handouts that we have created in our program and that we do disseminate to hospitals, community agencies, and our moms. So the first one is Coping with Infertility and Loss, and it talks about how to manage all those feelings and things that tend to happen when you're dealing with infertility. A Hope for Healing, a guide to depression after pregnancy and infant loss, that also has some resources for someone who's dealing with a perinatal loss. And then of course this one, we can't forget about our dads, last but not least. And right here we talk about what are some of the common signs of paternal depression, what are things to look out for, and then we also talk about what are some of the resources that are available if a dad is dealing with paternal depression. So this is just an example of some of the handouts that myself as well as my team have created and that we do give out. And again, these handouts were created based on feedback that we had received from professionals, from parents looking for guidance on how to deal with these different topics. Next slide, please. Okay, so now we're going to talk about my baby. And I call it my baby because this is a program that myself, as well as my director, Irina Inventora, that we sat together to really put together almost 10 years ago. So this is our emotional health phone support program. So this is the meat. This is the biggest thing that we do in our emotional well-being program. And I can sit here and talk about it for 20 minutes, but I don't have that time. So I will try to do it justice and go through these bullets and information quickly. So basically, the main focus of the emotional health phone support program is to serve as a continuum of care. It is specifically designed for those people that fall within that perinatal period. So if you go back to the previous slide where I talked about the bullets in terms of like, if you have an abortion, a pregnancy, if you're pregnant, if you have a child under the age of 1, adoption plan. If you fall in any one of those categories, that you would qualify for the phone support program, as well as our support groups, which I'm going to talk about in the next slide. So for our emotional health phone support program, how it works is that consent forms were created. And then what we did was we met with different birthing hospitals and birthing centers in our northern region. And we presented them with this program that would serve as a continuum of care for their clients. So what happens is a fax is filled out and it is sent to us on a confidential e-fax line that only myself, as well as one other person on my team, have access to. The referral comes in based on the target area of where the client lives. They will be referred to a perinatal mental health coordinator that targets that specific region. It is up to the perinatal mental health coordinator to then reach out to that client with the client's preferred method of contact. So that could be via phone, that could be via text message, and that could be via email. And each client is followed up a minimum of 2 times from this perinatal mental health coordinator. And the ultimate goal of this program is to ensure that clients are getting connected to mental health services or support groups in the area that they live in. So what is the role of the coordinator? The role of the coordinator is to check in. There is a script. I say script because obviously it's something that could be modified based on the needs of the client, but each coordinator has a script that they follow where they check in with the client, see how they're doing, and ask them a certain set of questions. And then based on the answers to the questions, we'll determine when that client is going to be followed up next. Typically, if it's someone that's getting a mental health referral, they'll be followed up within a week to find out what happened. Were you able to get an appointment for therapy? If not, why weren't you? If if you didn't go to your therapy appointment after it was scheduled, what were some of the barriers? So the whole purpose of this is to kind of knock down those barriers and get those women into care that need it. Because like we know, 50% of women that are diagnosed with postpartum depression, they're not getting the level of care that they need. So that's the whole purpose of this program, is to make sure that this is being done. We do have some hospitals in our target areas that will offer this program to every single patient that falls within that perinatal period, which is fantastic because that's what we want. We don't necessarily, we'll take those women that are high risk, but we know that once they leave the hospital, that they're probably going to be connected with services through social work. So what we want is we want those clients that score a 0 or a 1, we still want them to be referred to us, because once the weeks have passed, that's when a lot of clients really start to not feel well emotionally. Now what? Now where do they go? Because they scored low in the Edinburgh postnatal depression scale at the hospital, so they weren't able to leave with any referrals. So that's the whole purpose of why we created this, and why the gold standard is to really get all of the hospitals referring to us with every and offering it to every client that they have that's delivering. And like I said, each perinatal mental health coordinator has target areas that they work in. And the reason behind this is because we really want them to get to know the hospitals, to get to know the staff at the hospitals, to be able to build that relationship with the hospitals, as well as community resources and community agencies for the clients that they're going to be working with. And just to let you know, a lot of birthing patients want this service and utilize this service. And it's not that a lot of the referrals that we're getting are those that are experiencing postpartum depression, but a lot of the referrals that we're getting are those clients that really just want that comfort of someone checking in with them to make sure that they're going to be okay, and just to put it into perspective, in 2022, our program received over 5,500 referrals. That's just referrals. That's not including the calls that my staff has made. 5,500 referrals. So we see that the need is there and that clients are really wanting that connection to be able to have someone to go to if they do find that they're not doing so well emotionally. Next slide, please. So these are our consent forms. They were actually recently modified as of July 1st. And the reason why we did some modifications is because we wanted to capture a lot more demographic information. We wanted to know, what is the client's background, what is their insurance status, and what is the type of insurance they have? Because if we see that they're scoring high on the Edinburgh, or the doctor or the nurse is writing that additional information, in that section, saying that there's a history of a mental health issue, or the client didn't seem to be doing well in the hospital, we want to know that, because at least if we have their insurance status, we can start beginning that work to get them connected to care. It's a very simple consent form. It talks about what we do. It's it's fillable. It's on Adobe. They can write on the computer and send it to me. And this is just the information that we're looking to capture. We just want mom's contact information. What is the preferred method of contact, email address, signature, some demographic information, as well as the information of the individual that's making the referral, because sometimes when faxes come in, the language is not quite clear. So the coordinator may have to reach out. The reason why we decided to do 2 different consent forms is we wanted the language to be different, and we wanted to make sure that the referrals that we're getting are not of a fetal demise, what filled out on a consent form that is for someone who gave birth. So we wanted to make sure that that's not happening. So we decided that if we separated the consent forms, that we did something that made that perinatal loss consent form look different, that will then make sure that we're getting the right information for the right client on the right consent form. We do have these consent forms in a lot of different languages. For those of you who are not aware, in North Jersey, we have a huge population of people from all different types of backgrounds. And because of that, we want to make sure that all the materials that we do provide are reflective of the target audience that we have. So all of our materials, the consent forms, the handouts that I just showed you, they're all available in English, Spanish, Arabic, Portuguese, and Haitian Creole, because those are the main languages that are spoken in North Jersey. Okay, next slide. Okay, and then this is the next piece of what I'm going to talk about when it talks about our services, which is another huge component of our emotional well-being program. Prior to COVID, we did used to offer in-person groups, but once COVID started, we knew that that wasn't going to be feasible. So we, my director and her and I were talking, and she's like, let's do virtual support groups. So we started doing virtual support groups, and they have taken off successfully and are still up and running with a pretty, a good amount of people that are still attending on a weekly basis. So we have 4 different support group options. The first one is our Circle of Hope, which is a group specifically for women of color. Then we have a new mom support group. We have a Grupo para Nuevas Madres, which is our Spanish-speaking group. And then we have a pregnancy and new mom support group. And then we also offer a pregnancy and infant loss support group that meets every other Thursday at 6 p.m. So these are the groups that we have running. They're ongoing. They've been meeting weekly since March of 2020. And I have to tell you, we have a lot of our clients that religiously are coming on every week. And I think, I think in one of our most popular group is has been our Tuesday group. And in that one, we've had close to 20 people that are coming weekly. So virtual groups, I don't see it going away with us, but one of the things that now that things are starting to open up a lot more, when we're thinking of next steps and where do we want the emotional well-being program to go in the coming future, is we do want to start incorporating more in-person groups. Virtual is great. Clearly, there's still a need there since the attendance has been so high for us, but there's nothing that beats that face-to-face connection. So we do have some groups that we are looking to start over the next couple of months. We are looking to start an in-person Haitian Creole speaking group. We're looking to start another Spanish speaking support group that's in person. And we are looking to start, actually, instead of one Spanish speaking group, we're actually looking to start 2 Spanish speaking groups that will take place in 2 different areas. So we have 3 potential in-person groups that are going to be starting probably beginning of end of April, beginning of May. So that's something that we're looking to add on. And, as far as where we're headed, it's more in-person stuff. I think the virtual realm has been fantastic, but one of the things that we're noticing in our catchment area is that there is a longing to do more in-person things. So that's something that we're looking to do, and just to continue to expand and modify our emotional health phone support program to fit the needs of the ever-changing community. So yeah, next slide. And that's it. This is my contact information. Please feel free to reach out to me directly if you want to pick my brain, if you want to talk about maybe the possibility of getting something like this started by where you are. I'm always happy to meet. I'm always happy to talk about this program. As you can see, I love it. It's dear to me. And please do not hesitate to reach out. And I'm done. And I'm going to pass it along back to Kathy.
So that was a hard act to follow. The partnerships region is considerably larger than the Central Jersey region. And it's sort of a joke in New Jersey. Does Central Jersey even exist? Or is it just a state of North and South? Well, hopefully at the end of my presentation, you will be a believer that there is such a thing as Central Jersey.
Kathy, before you start, I do want to say this. As a New Jersey native, there is such a thing as Central Jersey. I grew up in Central Jersey. So yes, there is such a thing as Central Jersey.
Thank you. Thank you. So Central Jersey Family Health Consortium's mission is on the screen for you. In fiscal year 2022, which ended June 30th of last year, you can see the statistics on the number of clients that were served by the consortium, professionals educated, and the amount of funds that were donated to clients and families. This is our 6-county plus region. We do cover 1 city in Union County, which is technically part of the northern region, but we do cover that city. And unlike Evie's program, all of my staff works with clients from all of the counties. They're not, they don't specialize in one particular county. So we all have to be experts in the resources throughout the region. So this is from the consortium's website homepage. You'll see some of the programs that we offer. And I've listed a few others at the bottom of your screen. Of course, we're here today to focus on the pregnancy and parenting wellness program. So prior to October of last year, the program was called Perinatal Mood Disorders Initiative. And if you remember from the opening part of this session, that was the original name of the program that was initiated and funded by the Department of Health. So we thought after 16 years, number one, it's no longer an initiative. And two, we really found in the last few years that the population that we serve was kind of put off by the term perinatal mood disorders initiative for a variety of reasons, be they cultural or just fear that maybe we were reaching out to them because we knew something that they don't know about themselves. And so we made the change because what we really do is focus on wellness and how to make mothers the best parents they can be. So we changed our name in October, and the feedback has been very positive. You can see our statistics for fiscal year 2022, the number of clients. We have a 20% Spanish speaking population among our referred clients, and about 2% speak other languages. The 3,100 clients that were referred represent I believe it was an 18% increase over the previous year, which was 20% over the previous year, and the numbers just keep going up. We're on target this year to have 3,600 referrals. So there have been, we're growing by leaps and bounds, which is wonderful. Is that because more people are learning about our program and want to, have somebody follow up with them? Or is that because more people are suffering? It's probably a combination of both. My staff includes myself, a full-time advanced practice nurse, as the program manager. In 2022, I had one part-time perinatal social worker who has since retired. And now I have 3 part-time health educators. So we are currently a staff of 4 people, all very, very passionate. One of my health educators has been with the program since very early in the program, which is wonderful. Our referral sources are primarily our 14 birthing hospitals and 2 birth centers, but we also receive referrals from primary care and prenatal clinics, private OB provider and primary care offices, community agencies, home visiting programs, and mothers can self-refer to our program. So maybe they picked up a brochure, one of our brochures from the hospital, and for whatever reason, they weren't referred during their birthing admission, but 7-8 months later, they may be suffering, and so they call and ask for help. As Evie said, clients must consent to be referred because we are receiving, the hospitals are releasing their protected health information, so they must consent. Prior to very recently, March 1st, our referral forms were faxed or emailed to us securely. They too were faxed to a private electronic fax that comes directly to me and only me. We have since transitioned to a web-based referral process through a company called Gomo Health. So this is the top of our new referral form. Our primary motivation for changing to a web-based system is, as you can imagine, we all think that our handwriting is perfectly clear and that others can read our handwriting. But I don't even remember the number of hours. I want to say it was close to 1,000 hours a year that I was spending clarifying information, wrong phone numbers, not being able to read the mother's name. It was a tremendous amount of time, which really impacted the time that I could dedicate to working with my own clients, as well as expanding our program, providing education, etc. So This was just implemented on March 1st. We have definitely had some hiccups, but we think in the long run, it will work very, very well for our hospitals and our agencies. And as of April 1st, we will no longer accept faxed or emailed referrals. Our services are similar to the partnerships in that we provide emotional support and or bereavement support to pregnant and postpartum birthing people. That is the bulk of what we do. That's what the majority of our time is spent doing. And it's by phone, text, or email. Again, as Evie said, we asked the client what her preferred method of contact is. And we follow, the remainder of the follow-up contacts are conducted via that method. We also contact mothers at least twice. If on that second contact, she says, I'm good, or we think, she's told us everything's fine, we will then close the case and let her know that we're available if needed until her baby's first birthday. But the large majority of our client cases are open for about 3 months, which could be on average probably about 6 to 7 contacts if you're talking about the postpartum period. If someone is referred during pregnancy, we follow up with them at least every 3 to 4 weeks for the remainder of their pregnancy. And then for that first 2 to 3 months postpartum, as long as they continue to consent. And we always ask them for permission to contact them again. The feedback that we have from mothers is probably very similar to what Quinn and Evie hear, that they just appreciate someone calling or texting to check in on them, because often the primary focus is how's the baby doing? And the mom or the birthing person is kind of lost in the shuffle. We don't want that to happen. And they're so grateful that someone actually cares about how they're doing. Some of the services that we provide to our clients, we refer to a lot of support services, such as home visiting programs. Through our own agency, we have many support groups for new parents and grieving parents that are offered by the hospitals and other agencies in our region. We refer many times to lactation consultants. It's hard when you are discharged at 2 or 3 days postpartum. It's hard to master breastfeeding in 72 hours or less. So we find a lot of the moms that we work with are struggling, and they really need some information about where they can get support from an expert. We refer to community agencies to provide certain services like car seats, diaper banks, food banks, etc. And then, of course, behavioral health providers. We have a database of therapists based on the insurance plans that they accept. Although most of the therapists in our region do not accept insurance, unfortunately. So the ones that we do refer to are, they're very, very busy. And sometimes they're not able to accept a new client. So we provide several names to each mom and advise her to contact all of them in the hopes that she'll be able to get an appointment with someone. Excuse me, so sorry. We also provide education about PMAD to professionals in basically any setting. If you will allow us to come, we will be there. So we're going to private provider offices, inpatient nursing units. I went to a 50-person OBGYN meeting on Monday virtually. And then we also have a regional bereavement task force that we organize, and the meetings, we moderate those meetings. Basically, the people who attend those meetings are the perinatal bereavement coordinators for our birthing hospitals. And it's a really nice opportunity for them to share information on what they're doing and ask questions and get information from the other hospitals. With the birth of our new web-based program, let me take a step back. A year ago, we started offering a free text program. We would discuss the program, present the program to our clients, and then ask them if they wanted to enroll themselves or if we could enroll them. With starting the web-based referral program, now they are automatically enrolled in this text program because it's provided by the same company as our referral program, Gomo Health. There are 2 tracks to the program. There's a pregnancy track and there's a postpartum track. And the mothers receive 3 to 4 automated texts a week. And they're timed based on the due date or the delivery date that's entered at the time of enrollment. So if someone enrolls during pregnancy at about 36, 37 weeks, one of her automated texts will be, "Have you given birth yet?" And if she has, she enters the date of her baby's birth, and she's automatically converted to the postpartum track. If she hasn't given birth, those messages will come once a week until she enters her baby's birth date, up to 42 weeks. The content of the texts are supportive, motivational, or educational. There are also 6 keywords like song or joke or care that a mom can text and get an instant message 24/7, 365 days a year. The songs are very upbeat songs. Obviously, a joke hopefully puts a smile on the mom's face. And then through the links in the texts, mothers have access to a mini library of evidence-based information on pregnancy, the baby's first year, and her transition to parenthood. Again, all timed. For example, if the baby is 3 months old, the information that she'll get and she'll have access to is appropriate for a 3-month-old. If she's 28 weeks pregnant, the same applies. It's important that I share that all of this evidence-based information was reviewed, edited, and updated prior to our go live. This is the first perinatal mood and anxiety text program that this company has offered. They have offered postpartum programs in the past, but generic postpartum programs. So they sent us many hundreds of pages of education that was provided in their generic postpartum education program. And my team and I reviewed every word, every video, every link, every text message to make sure that everything was evidence-based and current. And there were a lot of revisions made. It took a tremendous amount of time to do this, to make sure it was the best product available for our clients. So as I said, our contacts are by phone, text, and email. Typically, we will send an introduction text upon receipt of the referral. "Hi, I'm so-and-so. I work with the Pregnancy and Parenting Wellness Program. You agreed to release of your information so I could follow up with you when you were at Main Street Medical Center," so they know who we are, where we got their information, And we also tell them approximately when we will be following up with a phone call, which is within a week of that introductory text, depending on where it falls in the week. Meaning we only work Monday through Friday. So we don't make contacts most of the time on the weekends. You're looking at 2 of our homegrown brochures. We don't want to forget about fathers either. And in fact, one of the support groups that we offered for more than 2 years, starting in May of 2020, was a new fathers support group, which was very, very successful. Unfortunately, my staff, my social worker who ran that group, has retired, and so that group is no longer being offered. Support groups. Our support groups are conducted by our hospitals and community agencies. And until my social worker retired, also by my social worker. In fiscal year 22, they conducted almost 450 groups in English and 89 in Spanish for almost 3,000 English-speaking attendees and 1,100 Spanish-speaking attendees. So we support our support groups by paying them a stipend for every group that they hold, where last year it was where 1 parent or more attended, now it's 2. They submit a voucher listing the topic, the number of mothers, fathers, support people who attended, and they are reimbursed $100 for each meeting that meets the criteria. We initiated a client satisfaction survey in February of 22, coming from a hospital background. Prior to coming to the consortium in 2019, I was used to quality improvement projects and looking at a lot of data all the time. We get a lot of positive feedback from the moms that we work with, but I really wanted some data, basically. So we created a Survey Monkey survey in Spanish and in English that mothers can complete anonymously. I believe it's 5 questions. It's a Likert scale that they rate the program, and then there are free text options for them to fill in their comments. What was best about the program, what wasn't so great about the program, how could we make improvements, and do you have any final thoughts? 97% of English-speaking clients who completed that survey rated it as either good or very good. The majority were very good, as were the Spanish-speaking respondents. 95% of them rated the program, the follow-up program, as good or very good. So we're very happy about that, and they've provided us with very complimentary statements in the survey, which is just makes us reinforces that we're doing a good job. We are headed in the direction of getting back to in-person education, which is fantastic. So we are going out to community events, hospitals, agencies, etc. As I said, anyone who will allow us to come, we will come. We're using more webinars. One thing that I'm really excited about, we've talked about dads already, is we have a webinar series coming up this summer, 6 sessions, where 2 fathers who both experienced perinatal loss. Their wives both had stillborn daughters at full term, and we are doing a webinar series on fathers and loss. We know a lot about mothers. Mothers, tend to be very open and expressive with their feelings, and we don't know a whole lot about what fathers experience. So Matt and Simon are going to share their experience with us from the moment that they found out that there was a problem to the point where they and their wives started to try again. And I'm happy to say they both have had babies since their losses. We are also partnering with Rutgers University's School of Public Health to do a research study in one of our areas in Mercer County, looking at the emotional and mental health needs of immigrant women in Mercer County. Trenton, the state capital, is located in Mercer County. There is a huge Latinx population in Mercer County, and we've come to know that we're not meeting their needs as best we could. So we want to learn more about what they need in a very formal way by doing a research study. Here is my contact information. Just as Evie said, you may contact me anytime with any questions about anything. So please don't hesitate to reach out. And I will pass the wand to Quinn.
Thank you. Thank you, Kathy. Again, Quinn Injemy from the Southern New Jersey Perinatal Cooperative. And as my colleagues talked about the history of how New Jersey came to embrace work around postpartum wellness, the program that we run with the funding from the New Jersey Department of Health is called the Postpartum Wellness Initiative for South Jersey. Next slide. So, and you can go to the next slide. So again, at the cooperative, our mission is to really support families in our southern region. We serve the 7 counties southern region, which is, in terms of geography, we are quite large. We do have some small urban areas. However, it is a largely very rural area. In enacting our mission, the cooperative strives to maximize resources and address gaps and barriers to care to help meet the needs of our communities. Next slide. So the cooperative is 40 years old. We just celebrated our 40th anniversary in 2022, and we are, as the other consortia, licensed by the Department of Health in New Jersey as a regional maternal child health consortia, and I've listed the counties that we serve in the South. Although we do focus mostly on the southern region, some of the programs that we run in the agency are statewide. Next slide, please. Our postpartum wellness initiative program does solely focus on the southern region. So our organization is led by a board of directors on which each of our member birthing facilities, we have 12, have designated seats. We have senior leadership, and we also have a subsidiary agency, Family Health Initiatives, which it's an organization that focuses largely on data management and analysis with programming that runs actually locally, statewide, and nationwide. Next slide. And this is just a graphic. It's relatively new here at the cooperative that exemplifies a multitude of programs that we're running to serve families, from everything from youth development, healthy homes, mental health, substance use programming, and certainly pregnancy and parenting. Next slide. So our postpartum wellness initiative for South Jersey was created in 2007. Very grassroots and really in response to, as Evie exemplified, response to the changing legislation around screening pregnant people, postpartum people. Next slide. And so the intent was to develop a system for providers to help them comply with the law and identify birthing people who are at risk. We did this by developing a universal web-based screening system for providers. Next slide. And so it all starts with the screen. So our web-based system employs the Edinburgh postnatal depression screen. We have our web-based system is HIPAA compliant. We have about 49 outpatient providers who take part in the system. It's completely free to any providers that want to be a part of it. Basically, it's an assessment, triage, referral, and follow-up telehealth service. So screens are done in the postpartum outpatient care setting. Providers can choose to screen pregnant people. So during the pregnancy, birthing people can be screened, and certainly postpartum. And from there, we receive all the screens done, and with patient consent, we then attempt to contact any patients who screen positive. So we actually have kind of a stepped level of care, and we are identifying women that aren't screening to suggest high levels of risk. We also are offering intervention to people that score in a lower area of risk. So for those individuals scoring in that kind of subacute range, we partner with Influence Innovations, which is the company, an Oregon corporation, who at this point, they deliver a program called Mom Mood Booster, which is a copyrighted, evidence-based, web-based program developed over 13 years ago by a multinational team from Oregon Research Institute, Parent Infant Research Institute in Australia, and the University of Iowa Depression and Clinical Research Center. Mom Mood Booster is a 6-session evidence-based CBT program for birthing people with mild to moderate postpartum depression, and we collaborate to bring this opportunity to the people in South Jersey who may benefit from it. Our PWI team, which consists of 3 licensed master's level social workers, function as personal coaches to this web-based support intervention. For those individuals who screen at a higher level, our 3 clinicians are contacting those folks as well. They're doing assessments, they're triaging them, they're coming up with plans for them and helping them link into whatever support the patient may need. They do psychoeducation with the patient. We send a plethora of handouts, much like the handouts that Evie showed, to help educate birthing people and their families about postpartum mood disorder. We do follow up with these clients for around 12 weeks. So that's ongoing support to make sure they get linked. And then we actually do closing summaries, which our providers have access to. So we just did some quality improvement over the last year for our web-based system, where when our staff submits a closing report on the provider end, the system notifies the provider that there is a closing summary ready for their viewing, and they're able to open the portal on their side and take that closing summary to incorporate it into their patient chart. Like Evie and Kathy described, we too do workshops throughout the region, both for consumers and also for professionals. We engage in community outreach, educational events where needed, and a plethora of professional workshops. We partner both internally in our agency with other programs to bring professional education, and we also partner with occasionally with our member hospitals as well, around bringing education to the provider community. We do have some group work being done in our region. However, we haven't had as much interaction with clients and group work. So we definitely refer into any of the hospital-based groups that are going on in our area. And we actually also have a facilitator guide and curriculum and training that we do with any organization that may want to start their own support group for postpartum people. We currently do have a hospital that we're collaborating with in our region who is interested in doing that. So that's exciting.
Thank you, Quinn. Thank you, Quinn. I just wanted to announce that we have 4 minutes remaining.
Okay, great. Thanks.
With your permission, Quinn, we can open up to questions from attendees. We do only have a few minutes for questions, but if you do have questions for Kathy, Quinn, or Evie, please put them in the Zoom chat. And if we cannot get to your question, we will record them, and the hosts will, the speakers will address those questions in the Whoop app.
I'm not seeing any questions. Anybody else?
If we don't have any questions, Quinn, if you want to continue.
Okay, great.
go ahead,
Yeah,
and if
sure.
we do see anything come through, I will record it.
Okay. If you want to flip the next slide, Kathy, that'd be great. We also have a warm line to help capture any birthing people in our area that may need assistance, and perhaps their provider does not participate in our web-based screening system. We have a warm line, so those individuals are able to call, and our staff returns that call, and then if they have not been screened at their provider office, they can screen them over the phone and then offer them the same assessment, triage, and referral that all of our provider offices take advantage of. Next slide. And you can go to the next slide. I already talked about that. So, as our other, as my colleagues, talked about, we really pride ourselves on building collaborative relationships, engaging with our healthcare community. We do a pretty robust onboarding process for anybody who wants to take part, any providers who want to take part in our web-based screening. And it is open not only to OB providers, but family medicine, pediatrics as well. Those would all be appropriate venues. So we do have a question in the chat. Do you find that this has been successful within New Jersey, the warm line for evidence-based home visiting? Our state is beginning a warm line for do we find that the warm line has been successful? I think definitely for us, the warm line is necessary so that we can kind of maximize how we capture anyone who may need assistance. So I think that is definitely helpful. And I think it works kind of in concert with our statewide Speak Up When You're Down number, which that's not a hotline. Is that a hotline? Is that 24/7, the Speak Up number? Okay. So sometimes people are even sent from the Speak Up number to our warm line. But I definitely think that warm lines are beneficial. I think, we have to have multiple ways for any programming that is done, whether it's home visiting or, the kind of work that we're doing around telehealth. We have to have multiple kind of conduits for people to get what they need, because everybody's going to come at it with a different comfort level, for sure. And certainly my contact information is in the PowerPoint as well, along with Paul, who is our lead clinician in our postpartum wellness initiative.
All right, and thank you, everyone. Thank you, Kathy. Thank you, Quinn and Evie. That was an incredible discussion, and what amazing programs you guys have supporting mothers and families. So
Thank you.
so much.
Thank you,
you.
everyone.
Thank you. Thank you, everybody.